Great. Well, thank you very much for having me. We'll talk about kind of a North America experience. We'll go about the Latarjet procedure. So by the end of this session, you'll be more familiar with the technique of Latarjet as well as arthroscopic Latarjet. Hopefully the evolution of this to be able to recreate shoulder stability with recreating the glenoid, as well as management in difficult cases for this. We've already talked about the pathological changes after instability events. There's no question glenoid bone loss is probably going to be number one. We'll talk about that mostly. But when shoulders dislocate, there's problems. They're more than just glenoid problems, right? There's cartilage and degenerative changes. There's humeral lesions. We talked about the bipolar off-track lesions. There's the glenoid capsule that leads to some plastic permanent deformations and elongations of that we have to deal with. The ligaments will change, like that ALPSA, the anterior labral periosteal sleeve avulsion. The labrum will have more extensive damage. We already had discussions talking about getting to 270-degree or circumferential and including slap tears. And we have rotator cuff issues that we need to be aware of, including subscapularis insufficiency, which I'll tell you is probably one of the hardest things to manage. We don't have reconstructions that work quite the same. But glenoid bone loss, let's go back and focus on this. Glenoid bone loss happens, and the question is, how often does this happen? John Dickens in the States has looked at this, and the military recruits get an MRI before they even have shoulder problems. And what they found was patients with first-time shoulder dislocators lose about 6.8% of bone, whereas any of their military recruits that had more than one dislocation had an average of 22.8. So anyone you hear about having recurrent dislocation, be aware, you need to look at this more carefully. And the problem with this is acute versus a late dislocation. Patients having a dislocation less than 6 months have a 27% chance of having a cartilage lesion in the glenohumeral joint already. Those having a dislocation untreated for more than 6 months have a 73% chance of having a cartilage lesion. So patients with longer periods of instability have greater amounts of cartilage damage. We already talked about this engaging Hill-Sachs, so I don't need to go on this, but suffice to say that we need to consider both sides of the bone. Now, what should we do with shoulder instability? Essentially, this paper here in 2018 with Itoy looks at it to say that shoulder surgery really should be considered within the first 6 months of shoulder dislocation, because there are things that we cannot fix. We're going to start changing surgery and changing treatment to be able to optimize their outcome score, just like we're talking about for this Latarjet procedure. In fact, the biggest question is, when should we do surgery? Do we do this after the first dislocation? And the easy answer is no, we don't need to treat the patient immediately after his first dislocation. But we should definitely treat the patient before the second dislocation. And I think that's where everyone is getting into, talking about how to predict these future dislocations. Because just like we're talking about now, there's a cost to waiting on surgery after the first dislocation. You're going to change your surgical procedure, and you're going to change the outcome for the patient long term. Just a reminder on the factors, we talked about this instability index. The age is important, male sex, contact sport, hyperlaxity, and bone loss. But the only surgical modifiable factor is bone loss, and that's why we're going to talk about it. We all know this paper from Steve Burkhart in 2000, which says that if there's no bone loss, an arthroscopic Bankart repair works or only fails 6% of the time. But when you have an inverted pair with bone loss, which he estimates probably about 30%, it's a 70% failure rate. So how much bone is too much? And we're talking about this right now. Well, what's a critical bone loss? So Burkhart, a few years later, said it's 25%. This inverted pair, based on cadaveric studies, is 25%. Shin AJSM 2017 said we need to start looking at this at 17.3%. More recently now, in AJSM, we're looking at 13.5%, including Dickens in his study showing American football athletes with military recruits. And now we're saying off-track lesions and anything more than 10% bone loss, you really need to figure out something else, because soft tissue repairs are not giving the outcomes we really want, and the Hill-Sachs has something to do this as well. And how much is 10%? Well, Preventure put this paper out in 2010. 3 millimeters of bone loss on a glenoid averages 15% bone loss. So it is there more common than we're realizing. And how common is common? Well, you look at the literature that's out there already. Almost 50% of the cases reported in literature have more than 10% glenoid bone loss. So if you're not seeing it very often, it's definitely seeing you. Why is this important? Well, this is the surgical management. I really think this is how we need to start thinking about this. This is a modification of the American Academy template, and looking at both clinical and radiographic outcomes. Those less than 10% bone loss, we're talking about this arthroscopic or open Bankart, just like Professor Inho was talking about, does a wonderful result. But anything more than that, we need to start thinking about glenoid augmentation or bony augmentation, something that's more solid to be able to recreate the static structures of the shoulder. And probably the gold standard that we're already talking about is the Latarjet. It's long thought to be the gold standard, and the most important thing of what we do in surgery is we need to have it backed by evidence to know that things are appropriate. This is first developed in 1953 by Dr. Michel Latarjet. Briefly, it involves a transfer of the coracoid to the anterior rim of glenoid, and it works by 3 different methods. The first is a bone block method. The coracoid acts as a graft to increase the anterior to posterior diameter of the glenoid, makes it more difficult to dislocate. The conjoint adds a sling, and this sling is a dynamic reinforcement to the subscapularis where it moves it inferiorly to limit the amount of abduction and external rotation. So yes, it's meant to decrease range of motion. And the CA ligament repair helps to augment the capsular reconstruction afterwards. We'll get into the outcomes because that's really the most important thing. The outcomes show long-term, 10 years. So there's very few surgical studies that can give you long-term outcomes. And 10-year follow-up, a systematic review looking at 13 studies, 845 shoulders, shows significant improvement. Return to sport rate at 85%. Good to excellent outcome, 86%. Recurrence rate at 10 years, minimum 10 years, 8.5%. Only problem, arthritic change is almost 40%, and we can argue on how that happens. Probably the champion of this, Gilles Walsh, done more than anyone else in the world, looked at his long-term outcomes. Mean follow-up of 20 years, 68 patients with an open Latarjet, mean age of 29, and he's looking at all his reported outcomes and shows significant improvement in patient-reported outcomes, and his recurrence rate is at 6% at 20 years, and his arthritis rate is under 10%. So at the best of hands, best technique, most experience, you can get excellent rates. Pascal Boileau, well known for this, he's actually compared the bony reconstruction versus soft tissue, and what he's finding is open Latarjet procedure is more reliable in terms of shoulder instability when you look at this longer terms. Most reported outcomes are 2-year follow-up. And if you look at this graph here at 2 years in his comparative study, level 3 study of almost 200 patients, outcomes of Latarjet, the dark black line, is still improved compared to the Bankart. But you continue to follow this in years to come, and the failures from Bankart or soft tissue repair continue to happen year after year because the soft tissue stretches out. Whereas if you can get a bone reconstruction, the failures happen immediately and then stabilize. The more problem is arthritis afterwards. So no question, Latarjet is the gold standard for shoulder instability with bone loss. You can address the bone loss. You might be able to help with soft tissue as well, but it's non-anatomic. You're robbing Peter to pay Paul. You can have complication rates, especially early with neurovascular structures. We talked about the axillary nerve, neurovascular bundles right there. It can progress to glenohumeral arthritis. A systematic review saying upwards of 30% right now, or 40% rather. And probably the most important thing is it is difficult to revise if it should fail because your anatomy is completely changed. Nothing is normal anymore. So Latarjet will trade a decrease in recurrence rate for an increase in complication rate and difficulties with future revision surgeries. So what is there? Well, Laurent Lafont actually progressed this on to an arthroscopic Latarjet, suggesting that we can increase the visualization of this, allowing us to attack other pathologies that are happening at the same time to improve outcomes, allowing us to see better, because it's really hard to adjust where that graft is in the glenoid to decrease the chance of OA. But unfortunately, you still have to visualize the nerve because you still have to do that subscap split. So this arthroscopic Latarjet really allows us to get those things, get it in a better position, hopefully mobilize it, get it, decrease the risk of adhesions. And what he's able to find, his outcomes in 2009, of 180 patients, essentially got 88% back to pre-op sports. This is the average follow-up of over 2 years. Excellent outcomes, 91%. Good outcomes, 9%. So almost everyone doing great. His complications are hematomas, graft fractures, nerve palsies, and late complications with graft non-union and graft lysis. So looking at healing from this, he's also looked on with his other colleagues to show that they're getting less and less postoperative complications as they're teaching how to do this. But unfortunately, the French surgeons that's developed this has completely developed all the tools in the beach chair position. I'm a lateral decubitus surgeon. I know half the surgeons around the world are lateral decubitus. So I needed to switch this around. I could not do it in a beach chair. It's a very complicated surgery to do. So we've actually adjusted his technique to be able to do it all in the lateral decubitus to get the benefits of the arthroscopic Latarjet. But the problem we found, was that even though we get better at this, our complication rates did not. He found the same thing. So this is Laurent Lafosse's learning curve paper in 2019 showing that his first 25 cases improved over 5 different surgeons as you learn how to do this. Surgical time improved. However, complication rates did not decrease, and that is the risk of doing something like this. So no question now in 2020, arthroscopic Latarjet, you can have a better rate of instability afterwards. You can reduce those things, but there is a higher rate of intraoperative complications. So you have to be technically good at something like this. Our problem, of course, is that we had very few surgeons. In fact, very few surgeons ever took up arthroscopic Latarjet in the lateral decubitus position, really because of this high learning curve, not addressing the capsule, having difficulty with the nerve, splitting the subscap, having failure of that being difficult, and of course revision rates being difficult to deal with because the anatomy's changed. So really, we're talking about ideal surgical technique being arthroscopic, anatomic, having a low complication rate, preserving that subscap, addressing the bone loss, and doing that soft tissue repair, just like Professor Inho just talked about. And Matt Preventure in the U.S. really has pioneered doing that, using an iliac crest, a distal tibia allograft to be able to reconstruct this to make it like the Latarjet with the benefits. And the good part of this is that if you can recreate the bone, you can actually simulate the stability of the shoulder just like a Latarjet does, with the normal anatomy recreating the capsule. So this is a randomized control trial study looking at that exact question, iliac crest, so bone graft versus the Latarjet, showing exact clinical outcomes and radiographic outcomes. We've published our technique. We're not going into this, but we're showing that by doing this method of not damaging the subscap, we can have a much faster learning curve than the Latarjet, probably because we have less portals. So the same type of Latarjet, we're doing the same approach, but we're avoiding splitting the subscap. And in fact, by doing it in this way, we can actually teach this remotely. This is a teaching module that we had where a cadaveric lab happened in another country using multiple cameras. It's now safe enough to teach this technique to be able to reconstruct the glenoid bone, allowing where to put screws, how to modify it, how to insert it into the shoulder so that another surgeon can do this technique, perform it in their home country without ever having to travel again. Probably why it's beneficial is because we're now no longer needing to change anatomy. We're able to repair the capsule instead of looking at the Latarjet where we have the coracoid graft there. It's in a great position, but it doesn't stabilize it right away. Whereas we can, using the distal tibia, we can actually recreate that Bankart on top. We can stay away from the nerve by staying within the rotator interval. We've done the study showing that that's much safer, easier to teach, to be reproducible like this, and hopefully not having the subscap changes or the worry of a subscap rupture after this type of a surgery. Specific anatomic portals that we won't get into allow us not to damage the subscap like this. But again, the most important thing of something like this is to show the outcomes. And we showed our early outcomes, the 1-year outcomes, by going through the rotator interval to be able to attach this graft. No neurological and vascular issues that we would have with the arthroscopic Latarjet, with the same healing response as the arthroscopic Latarjet, with none of the complications afterwards. And this is our 2-year outcomes that we just finished publishing in 2020, showing that we're having excellent fixation, excellent healing, Similar resorption rates, and this is what everyone gets worried about, is the resorption rate can be upwards of 50%, but the good part of that is the resorption rate is the size of the glenoid and graft at the end is the same as a normal glenoid. And how does this look? Well, this is a 32-year-old female, had it dislocated, reduced and emerged. You can see the pre-op x-rays of that bone loss in the anterior inferior aspect of the glenoid, a pre-op CT with an on-face view with that glenoid loss, 3D reconstruction with that glenoid loss, and that bone actually healed quite medially. You can see more in the anterior plane. This is what it looks like. You can see we just finished talking about first-time dislocators going through, and the most important part looking at this is when we were able to put a graft inside without damaging the subscap, we can actually recreate the size of the glenoid bone. Here you can see from anterior to posterior, that's the size of the glenoid bone. And all I really wanted to show you here is that we can repair this with a Bankart repair like Dr. Ho showed, and that's the edge of it. And why I'm showing you the edge of where the Bankart is, that's the rim of the glenoid. Because now we're getting post-op views showing great reconstructions, remodeling of the bone, which is where people are concerned of, and we can see that the subscap has not lost its volume compared to preoperatively. But now at 6 years, because the remodeling, sometimes the screws are prominent. I do want to show this because this shows how the bone remodels and how it heals in there. She wanted her screws out. The rotator interval that we resected is completely regrown in there. But when we look to take out the screws, we actually have to release the Bankart that's repaired. This is the Bankart completely healed on top of the glenoid. You can actually see the definition between the normal glenoid and the Bankart that's repaired on top of the graft. As I release this Bankart, the important part was this is where that suture anchor was. And I'm just noting that because that was the origin of where the native glenoid is. Everything anterior to it is graft, and this is what it heals and looks like. As we take it down, we're just going to expose this here. I'm just going to get through. But this is the elevation. So using a cautery probe, everything anterior to this suture anchor is new graft. And you can see we've actually recreated, I'll get right to this area. We've actually recreated 7 millimeters of new graft healed 6 years out so that we can actually get this. So removing the screws improved her symptoms, got it back to where it wants to be. So hopefully we've been able to show you that Latarjet is no question the gold standard for treatment of shoulder instability with bone loss. Open surgery, no question, is reliable, usually successful, has some specific risks intraoperatively that with technical practice you can definitely avoid, but has the risk of post-op arthritis because it's hard to position that graft in the right spot. Arthroscopic anatomic glenoid may be our newer procedure in North America because we're finding it's a similar or faster learning curve like the Bankart, cost effective, allows us to repair the capsule, is safe, doesn't damage subscap, and is anatomic, now showing that we can actually recreate that bone. Thanks.